Well, thank you for that kind introduction. And I'll go ahead and get started. I have probably a little bit of overlap with the previous talk, so there's some that we'll be able to breeze through. The objective of my talks today, some of the introduction, I'll be able to skip through that. Just very briefly touch on some of the tools that we have for diagnosis. And then we're going to review the surgical principles of NETs, which I'm sure many of you are very familiar with. And I'm going to talk about localized pancreatic and small bowel neuroendocrine tumors. We're going to talk about the management of carcinoid crisis and the principles of liver cytoreduction. I'll review the current guidelines and then the role of the multidisciplinary approach. I don't have any disclosures. So just briefly, as you all know, and we've touched on earlier today, neuroendocrine tumors are rare, but maybe not so rare set of tumors arising from any region of the body, particularly the GI and the respiratory tract. Some studies have shown a slight predominance in women. There are many, many ways we can classify these tumors. One of the ways is functional or non-functional. So functional tumors are those that produce a particular hormone in excess, and they're often defined by the type of hormone they're produced. Some of examples are insulinomas and functional carcinoid tumors. Non-functional neuroendocrine tumors do not release hormones or have a clinical syndrome associated with their tumor type, but there may be other peptides or hormones secreted that we just haven't recognized yet. They arise from specialized cells, which have characteristics of nerve and hormone secretion, and these cells have different names. Particularly, one we'll focus on today is the enterochromaffin cells in the GI tract. And they're characterized by their expression of somatostatin receptors. And some have more somatostatin receptors or different types of somatostatin receptors on their tumor type, and that impacts treatment. And these receptors, as you've just learned, have many roles in cell proliferation, protein synthesis, and hormone secretion. This is an image just below of a pancreatic neuroendocrine tumor that's well circumscribed, and we'll go into a little bit of detail about that. And as you all know, there can be a wide discrepancy in the way these tumors present and what stage they present at. They're heterogeneous tumors, as we've heard, and unfortunately distant metastases can present in up to 60% of cases, meaning tumor that has spread beyond their primary site of origin. And there can be atypical symptoms or an absence of symptoms. Sometimes they're picked up incidentally when we're looking for other things on imaging, and many of them can grow very slowly, and so we may not know that they're there. This pie chart illustrates nicely the site of primary gastrointestinal and pancreatic neuroendocrine tumors and their rates of metastases. So you can see this discrepancy here. For example, appendiceal nets make up about 20% of all GEP nets or GI and pancreatic neuroendocrine tumors, but only 3% will have metastatic disease, versus our small bowel and pancreatic neuroendocrine tumors, which you can see over here, make up to about a third of the neuroendocrine tumors and have much higher rates of metastatic disease. So distant metastases, like I said, up to 60% of patients can present with this, and we mean disease in the bone or liver. The talk today will focus mainly on surgical management of the liver metastases. But the liver is the most common site of metastases in up to 80% of patients with well-differentiated neuroendocrine tumors. The primary cause of mortality is liver failure related to overwhelming liver tumor burden. And so that's the main reason why a lot of our focus on research and intervention focuses on the liver. They are both then understandably key prognostic factors related to survival in patients. I believe you've seen this graph in the previous presentation. This is a very well cited study and just illustrates the the prevalence of GEP-NETs, and you learned that they're the second most common compared to colorectal cancer in the United States, and compared to all cancers, neuroendocrine tumors are certainly on the rise. This finding was seen across all primary tumor sites and across all stages. Some of the reasons for this are certainly improvements in detection, improvements in how we're defining neuroendocrine tumors, the frequency of imaging that's performed, but the fact that we're seeing this across all primary sites and all stages and grades is significant. Survival by primary site, this is just repeating some of the previous information. I think the importance of this, I'm sorry, it's not, oh, here we go. I think these two bar graphs show the survival by primary site in the first chart, and then the survival across, I'm so sorry, I'm having trouble reading it. But what you can see here is that the as your stage increases, your survival decreases. And that highlights the importance of early detection and intervention. So very briefly, neuroendocrine tumor diagnosis requires a high incidence of, or a high index of suspicion. As we talked about, there can be numerous ways that these tumors present and behave. There are hormonal studies and tumor markers that your physicians may request. Imaging plays a key role in the diagnosis and staging as well as surgical planning of neuroendocrine tumors. So we have conventional imaging studies, which essentially most patients will start off with a CT scan, and then to assess other areas of the body for surgery, such as the liver, we'll generally order an MRI. And then there's functional imaging. Functional imaging includes octreotide scan, or octreotide scan, which has really a much older modality, which has been replaced by gallium and copper PET CTs. And then tissue diagnosis, of course. So whether it is CT guided or ultrasound guided or through endoscopy, obtaining that correct differentiation and grade of the tumor will be essential to guide management. Some of the hormonal markers we talked about, if we're talking about pheochromocytoma or paraganglioma, we may be ordering metanephrines or dopamine. For the pancreas, which will be the focus of one of the primary focuses of this talk, we can have hormone-secreting tumors such as insulinomas, VIP, and gastrin. For small bowel neuroendocrine tumors, serotonin, and for lung as well. I know we touched on this in the previous talk, but one of the key findings is the split between the poorly differentiated and grade 3 NETs. And what that's done from a surgical standpoint is increase the number of patients that might be able to undergo surgery in select cases. There are several staging classifications, and I'll go into some detail about that further, but as we know, increased stage of the disease portends a worse prognosis. I'll first start out by talking about localized and local regional disease, and beginning with pancreatic neuroendocrine tumors. So just a brief review of the anatomy of the pancreas. So the pancreas is a very friable gland. It does not have a great capsule, which creates a surgical challenge very often. It's a very leaky organ. When we're operating on the pancreas, sometimes just looking at it the wrong way is enough to make it want to leak on us. And so there's a very common saying, we don't mess with the pancreas. But for neuroendocrine tumors, we often are diving right in. So just the anatomy. So we have the head of the pancreas that sits in a very tricky area by an important part of our intestine called a duodenum. This is where all of our food that we eat and consume enters our stomach, passes through this area of the small intestine, and meets up with the pancreatic juices that help with our digestion. Tumors can arise in the head of the pancreas. We also have the pancreatic neck, as well as the tail. Now, the tail is different from the head, where the head is fixed against this area of the small intestine and attached by a ductal system that runs through the pancreas. The tail is sitting freely within the body and is often easier to access than the head, and that makes a big difference in terms of surgery. I mentioned this ductal system that runs through the pancreas, where all of our pancreatic juices collect and empty into the small intestine where it meets the food that we've consumed. And this pancreatic duct becomes an important consideration when we're talking about surgery. Because as we talked, the pancreas creates these digestive juices. And because it doesn't have a very nice lining like some of the other organs in our body, it's prone to leak, which can result in sometimes life-threatening or quality of life debilitating complications. Next, just briefly to talk about what we mean by a localized neuroendocrine tumor or localized tumor of the pancreas. They're classified as localized if the tumor has not spread beyond its primary site or beyond the tumor it arose from. So, for example, if the tumor has not spread outside of the pancreas, we'll call it a localized neuroendocrine tumor. So, just in general, and of course every patient's case is different, but in general, surgery is recommended for all functional pancreatic neuroendocrine tumors. These functional tumors are secreting certain hormones, for example, insulin. The insulin-secreting neuroendocrine tumors tend to be the least malignant of the group, whereas the VIP-omas, or vasoactive intestinal peptide, gastrin, and glucagonomas, have a much higher rate of cancer. For non-functional pancreatic neuroendocrine tumors, this is an area of rich debate among surgeons. But in general, and according to current guidelines, if they're less than 1 centimeter, generally observation is favored. If they're greater than 2 centimeters, surgery is recommended because of their higher cancerous potential. And between 1 and 2 centimeters, there can be all kinds of debate on this topic, but in general, surgery for select cases. And then this image just shows a tumor in the tail of the pancreas, and then you can see this arterially enhancing tumor in the tail of the pancreas along this view. This is if the patient's lying down and we're taking sliced images. I promise I'm pressing the forward button. There we go. So for localized tumors in general and for localized pancreatic neuroendocrine tumors, surgery offers the only chance of cure for these neuroendocrine tumors. So an oncologic pancreatectomy for neuroendocrine tumors of the pancreas greater than 2 centimeters in size, like I said, is recommended and according to current guidelines. I'll talk a little bit about each of these common procedures for pancreatic tumors. The resection should include the regional lymph nodes, so the lymph nodes draining the pancreas. Enucleation is where we're coring out the tumor and sparing the rest of the normal tissue around the tumor for select cases, and we'll talk about that a little bit. And then, of course, even though the goal is for cure for localized disease, all patients require long-term surveillance to monitor for recurrence. Now, to talk a little bit about the surgeries. So the first one I'll talk about here is enucleation. And enucleation, like I said, we are removing the tumor but sparing the remaining pancreas. So it's a parenchymal sparing resection. Primarily performed for insulinomas where the cancerous potential is at its lowest. Can also be performed in select cases where the patient may not be healthy or fit to undergo a much more advanced or larger surgery. Distal pancreatectomy, so very often these tumors can be located in the tail of the pancreas like we showed on the previous slide. And because the tail of the pancreas is often free, it's free from the small intestine and some of those major blood vessels that course nearby, it can be resected and removed. Sometimes it's removed with the spleen. Sometimes it doesn't have to be if it's far away enough from the spleen and the blood supply of the spleen. The spleen lives right next to that tail of that pancreas. And then the Whipple surgery, and many of you may have heard that term. So that surgery involves removal of not only the head of the pancreas here, but also that really important part of the small intestine that is just past the stomach where all of the food that we consume passes through. This removes the entryway or exit of that duct of the pancreas where all of those digestive fluid passes through, and then we reroute the intestines so that way patients can eat normally and the food will pass into their small intestine. So you can imagine not only is there a chance of leak from the new connection made from the pancreas, but also that small intestine is being reconnected. The bile duct here is being reconnected. And so there are actually 3 areas where patients can have complications from. So pancreatic surgery certainly could be a talk of its own, but I'll move along to small bowel neuroendocrine tumors, and if there are any questions, I'd be happy to take them during the panel. But just to switch topics a little bit to now small bowel neuroendocrine tumors, a little bit of the anatomy here. I like this picture a lot because it does show the blood supply and the drainage system of the small bowel. So the small bowel sits within our belly and has a fan-like distribution of our blood vessels. And this is very important because the neuroendocrine tumor that might be sitting in part of the small bowel has potential to spread to those lymph nodes. And so when we talk about removal of the intestine as well as lymph nodes, we're talking about removal of a portion of the blood supply of the intestine. So localized small bowel neuroendocrine tumors are ones that have not moved beyond that small bowel or beyond that initial lymphatic drainage system where that blood supply lives on the previous picture. They include tumors of the ileum and the jejunum. This is what is also termed our midgut neuroendocrine tumors. The jejunum is the most common site for small bowel neuroendocrine tumors overall, and the third most common site of all neuroendocrine tumors after lung and rectal nets. And it's the most likely to, midgut nets in general are the most likely to develop those distant metastases. And then this illustrates what we're looking at in the operating room. So this is a piece of the small bowel that the surgeon is holding, and we can see this white, almost scar-like appearance to the tumor and narrowing. This would be that primary tumor. And you can see it can cause constriction of that small intestine, so patients can develop abdominal pain, obstructive type symptoms, and sometimes no symptoms. So up to about 30% of the small bowel nets will be localized to the jejunum and ileum. And then 41% will present with regional lymph nodes, and then up to 30% with distant metastases, including liver and bone. This is an example of now that small bowel neuroendocrine tumor that we saw on the previous photo that was limited to the intestine has now spread to those lymph nodes nearby that important blood supply and drainage system of the small bowel. And you can see this sort of mass-like appearance here is a conglomerate of lymph nodes fibrous tissue, inflammatory reaction, and this can make for a surgical challenge because it constricts that blood supply. Patients may develop symptoms of abdominal pain, distension, obstruction, where the food can't pass through that small intestine, and a surgical challenge because removal of all of this tissue can become difficult. We need a certain amount of blood supply to our intestine in order to have a healthy life and eat a normal diet. And if this conglomerate of lymph nodes travels to more of that primary blood supply or central blood supply of the small intestine, they may not be a candidate for surgery. So the approach to a localized small bowel neuroendocrine tumor, of course, we want to offer surgery up front. We examine the entire abdominal cavity looking for a tumor that has escaped the primary tumor site. So, for example, the liver, the peritoneum, the lining of the abdominal cavity to see if there are any tumor deposits there. And that will help clinically stage the patient at the time of surgery. The small bowel neuroendocrine tumors, up to 50% of them can have multiple tumors or be multicentric. So we want to be very careful to actually palpate with our hands the entire length of that small intestine and feel for any small tumors that our imaging may have missed. We also want to palpate for any of those lymph nodes and remove that. So this is this image here is the small intestine with a primary lesion here, nodule or tumor. This is that blood supply and drainage system with these lymph nodes here. And you can see that this tumor has then spread to these regional lymph nodes. And so the goal of surgery is to not just remove that small intestine, but incorporate those lymph nodes with it. We call it a wedge resection of the mesentery to remove the associated lymph nodes. Liver ultrasound can also be performed at the same time to look for any liver tumors that perhaps our imaging has not picked up, and those can be biopsied or resected at the same time. And many times if it is detected before surgery, can be performed at the same time. And then this is an example of this patient actually presented with an intussusception, which is a pretty rare presentation for a neuroendocrine tumor. That is when the intestine has telescoped in on itself, and the patient presents with abdominal pain and obstruction where the food can't pass through because that intestine has formed this telescope and a blockage, essentially. Surgery for metastatic disease. So liver cytoreduction. Cytoreduction is another word for debulking, and it's there can be liver cytoreduction, there can be cytoreductive surgery performed for the abdominal cavity in general, where we're trying to remove all macroscopic disease. So this is considered an R2 resection. A complete resection where we can't see any of that tumor is considered an R1. And then if not only do we not see it, but there's no tumor on the margins of what we have removed microscopically, that's considered an R0. And so when we're talking about removal of 70% of the tumor burden or 90% of the tumor burden, that implies that we're leaving about 10 to 30% of the tumor burden behind, maybe because we can't remove it or it's in a tricky location. It would involve there being too much liver removed, and we do need a certain amount of liver to live healthy and normal life. And so for some of those reasons, a 70% or 90% debulking or cytoreductive threshold has been recommended. Now, although recurrence rates of our tumor is high after liver cytoreduction, surgery is often the recommended approach for select patients because it can provide a survival benefit and it can overall reduce symptoms if the patient is having a functional neuroendocrine tumor with significant tumor burden. Liver surgery can involve cytoreductive surgery where we're debulking. And then debulking implies that we're leaving the healthy tumor behind it. We're not looking for margins. They're also called, debulking tumors are also called parenchymal sparing resections, meaning the parenchyma is the normal healthy tissue and we're leaving that behind. We can also perform wedge resections where you are taking a little bit of a margin, and we can perform ablations at the same time. So many different ways to attack these tumors. Rarely do we need an anatomic resection where you're removing the right lobe or the left lobe or certain segments, because these tumors, they tend to be pushers, not invaders. And so they're not often infiltrating the normal healthy tissue. And so removal of that tumor without harming the healthy tissue behind can have survival benefit. The optimal threshold for cytoreductive surgery, this is often a very hotly debated topic in our meetings. But generally, when greater than or equal to 70% of the tumor burden can be removed, surgery is recommended. And again, to improve both survival and then improve symptoms in patients who have hormone excess and symptoms because of that. And this is a picture of what the liver can look like after debulking or cytoreduction. This patient had large tumors in different areas of the liver, and you can see those tumors have been removed, and now this healthy tissue has been left behind. Why pay attention to the liver? Well, we touched on this previously. Up to 60% of patients can present with metastases, the most common site being the liver. The primary cause of death is liver failure due to overwhelming tumor burden, and liver failure because of that. They are primary prognostic factors for patients with liver metastases, and select patients can have their liver cytoreductive surgery performed safely, and it's technically feasible to attack these tumors in the many different ways that I mentioned previously. And then what requires a multidisciplinary discussion is whether other modalities would offer the same survival benefit. When to operate. So many considerations. One that we've touched on and you might hear throughout these talks is the debulking threshold. So if we're able to remove up to 70 or 90% of the tumor. And this, there was a study performed looking at a little over 100 patients with pancreatic and small bowel neuroendocrine tumors, and this shows a greater than 70% debulking had been performed for patients, or less than 70% debulking. And you can see there's a clear survival benefit in the patients who underwent debulking. This was a retrospective study, and we can talk about the weaknesses of that, but many studies have shown a survival benefit when greater than 70% of debulking has been performed. When to operate? Well, for tumors that have favorable biology, like we talked about, neuroendocrine tumors can be very heterogeneous, and typically we're talking about the well-differentiated grade 1, grade 2 nets, very selectively for patients with well-differentiated grade 3 nets. And then, of course, important technical considerations. Is the tumor by critical structures? Is it by the major blood supply of the liver? We need a certain amount of liver to have a normal, healthy life, and if there's too much liver burden where removal would compromise that, well, then other modalities should be pursued. And, of course, the patient's overall health, their wishes, and their ability to undergo an operation safely. This just shows the part of the initial workup. This patient's undergone a gallium PET CT, and you can see the highlighted, or the areas that light up are tumors, and it's a pancreatic primary. This is after debulking has occurred, and you can see meticulously Each tumor from the liver has been removed, and you can see the segments labeled here from where they've been removed. And then what the final result shows is that same image where we have spared the normal and healthy tissue while removing all the visible tumor. And of course, I touched on this earlier, that, patients are best served when there is a multidisciplinary team that specializes in neuroendocrine tumors, that know the advantages and disadvantages of all of the treatment options that are available for patients. So each patient is different. Each tumor type is very different, as you've learned in the previous talk. And so many important considerations have to be taken into account before we recommend or take the patient to surgery. Of course, the patient's wishes. Are they a candidate for surgery based on their health, based on their tumor type, tumor location? Also, what is the goal of surgery? Is it curative versus palliative? Are we doing surgery to relieve obstruction or hormonal symptoms? And of course, what is the tumor biology? Fortunately, we have experts in other areas than surgery. For example, the local regional treatments that you'll hear about later today, ablative procedures. Some of these can be done during surgery. Some of these can be done by our colleagues prior to or after surgery. Then, of course, a number of systemic treatments, which we'll work with our medical oncology colleagues on. And all of these experts are discussing the patient every step along the way in their care to determine, what's best along with the patient's preference as well. I'm going to touch a little bit on carcinoid syndrome and carcinoid crisis. Carcinoid syndrome, of course, much more common than carcinoid crisis, but all of this is result of serotonin. So we do have normal serotonin production. We've all heard of that. Serotonin is produced from the amino acids, the proteins that we eat in our diet, and it's converted by this mechanism to get to the serotonin that can cause the symptoms that we know about from carcinoid syndrome. It's stored in various types of cells, and you can see here those enterochromaffin cells of the GI tract then produce and store serotonin, and then to a lesser degree some other cell types, such as in the brain and our platelets. Carcinoid syndrome, so for functional neuroendocrine tumors or functional carcinoid tumors, serotonin can also be released into the circulation, causing what we know of as carcinoid syndrome. It tends to be episodic in nature, so sometimes difficult to diagnose in patients who don't already have the diagnosis of a neuroendocrine tumor. They can have symptoms of flushing, diarrhea, crampy abdominal pain, and this can be caused with certain triggers. Serotonin is converted to 5-HIA and then excreted in the urine, and so sometimes it may or may not be elevated at the time that the patient comes in for testing. Carcinoid syndrome can not only can it lead to the hormone excess and the symptoms of the hormone excess, but that excess serotonin in our body produced by that tumor can also lead to a number of other effects, which you've heard of previously, like carcinoid heart disease, and can cause structural changes in the heart, as well as mesenteric fibrosis. So that image I showed earlier of the patient with the carcinoid tumor of the small intestine, they could have an exacerbated or large inflammatory response related to their serotonin, and that can contribute to fibrosis of the mesentery, which can also make for a surgical challenge. Below, I listed just the frequency of some of the symptoms associated with carcinoid, diarrhea, and flushing being the most common, but there are a number of other effects of carcinoid syndrome like crampy abdominal pain, wheezing, arthritic type symptoms, and certainly many others. Carcinoid crisis is a different entity. It's a rare condition that happens primarily with patients with small bowel neuroendocrine tumors. Are at higher risk for it. Patients who've had previous carcinoid syndrome are at higher risk, and older age patients. It's a rare but fatal condition. We often think of it as, we often worry about it as surgeons at the time of surgery because patients are undergoing a stressful time, undergoing anesthetic agents and a long surgery. They can be at risk for a carcinoid crisis. It has been difficult to define the prevalence or the rate of carcinoid crisis because many will define it differently. It may go under-recognized during a procedure or a surgery. And so studies have who have looked at carcinoid crisis during times of surgery or procedures have listed anywhere between 0 and up to 35% of patients. The hallmarks of carcinoid crisis, first and foremost, are hemodynamic instability, so low blood pressure that requires fluids and medications to support that blood pressure and bring it back up to normal, flushing, diarrhea, bronchospasm as well. And then because the body gets so sick from all of this and you have that low blood pressure, you can also be at risk of kidney disease, liver failure, and heart attacks. It's associated with secretion of serotonin, but we also think other mediators can be involved as well, and some of these other proteins like histamine, bradykinin. And then the triggers of carcinoid crisis, general anesthesia, procedures or surgeries, PRRT has been linked to carcinoid crisis, and liver-directed therapies. The carcinoid crisis guidelines are pretty vague. The octreotide has been considered standard of care for patients with carcinoid syndrome and carcinoid crisis, but their efficacy is really unclear. You can imagine if it's been hard to identify the rate and prevalence of carcinoid crisis, if we can't correctly identify it, then it's hard to determine if we're correctly treating it. But octreotide is the mainstay. A lot of this data comes from retrospective studies, which have some weaknesses and for us to be able to draw conclusions of their findings. The resuscitation or the treatment also involves resuscitation, which means supporting their blood pressure with fluids, as well as medications that will bring up the blood pressure. Guidelines are also different with respect to how they recommend management of carcinoid crisis. The European guidelines have put in some dosing of IV octreotide during surgery or during procedures. NANETS sort of leaves it open and really doesn't define it clearly. There are other institutional protocols. For example, the Mayo Clinic has their own protocol. Other institutions have their own preferences for how to manage carcinoid crisis. I would say the most important thing is if you feel like a patient is at risk and they're undergoing surgery, there has to be a conversation between anesthesia, the patient's oncologist, and surgery so that preparation has been made in the event of this rare event. So we talked about the multidisciplinary approach. This should always be done ahead of surgery. For high-risk patients, there has been some recommendations for perioperative infusions of octreotide or preoperative treatments with long-acting somatostatin analogs. And then for hemodynamic instability or that low blood pressure that doesn't respond to the previous efforts that I mentioned, can be given IV injections of octreotide with higher doses. That wraps up my discussion of carcinoid crisis. So I was going to touch a little bit on the guidelines and what the current guidelines say about the management of neuroendocrine tumors of the pancreas and neuroendocrine tumors of the small bowel. So, and a lot of this we've already talked about, but in general, for well-localized, well-differentiated neuroendocrine tumors of greater than 2 centimeters, or this first is less than 2 centimeters in size, observation is generally recommended. And like we talked about, between 1 and 2 centimeters in size, hotly debated topic, surgery for select cases. But here, the NCCN breaks it down into less than 2 and greater than 2. And then for greater than 2 centimeters in size, surgery is recommended. And you could see here the pancreatic duodenectomy, that's the Whipple procedure. If the tumor is in the head of the pancreas, and then if it's in the tail or distal end of the pancreas, then distal pancreatectomy. And then you can see here both strategies involve in removing the lymph nodes that live nearby. For tumors of the GI tract, essentially for all local regional disease, if the patient is a candidate for surgery, we really want to offer small bowel resection and then removal of those mesenteric or regional lymph nodes. And then for metastatic disease, we talked how that is really requires a individualized treatment plan for that patient. There are numerous ways to attack these tumors. If resection is feasible and we're able to achieve, according to the NCCN guidelines, greater than 90%, according to NANETS, greater than 70% of cytoreduction or debulking or reducing that tumor burden, then surgery is often the treatment of choice. This is just an example. I'm not going to go through all of this, but this is just an example of a possible treatment algorithm, and many institutions have their own. But I like this one just because it shows just how many ways that we have of attacking these tumors. And this is including many different approaches from the different experts in the care of NETs. We talked about early diagnosis being key. When we can treat these tumors when they are localized and they're confined to their primary site, that offers our best chance of cure. We talked about multimodal treatment plan for patients. All of these patients really require long-term surveillance and preferably by a neuroendocrine team. Regularly discussing them at our tumor conferences, as well as their candidacy for clinical trials if they're available. One of the key elements that sometimes we forget in the management of NETs is that patients don't have solely their neuroendocrine tumor. They can have many other health issues as well. And so studies have found that patients who have a primary care team that's looped in on the patient's neuroendocrine care, they do better than patients who don't. And then, of course, support and advocacy. And you all are here, so I don't have to tell you that. Thank you so much for having me. Hopefully I didn't run over, but I'll be happy to take any